All right. Hi, everyone. My name is Melissa Verseman. If I haven't met you or haven't worked with you, I'm a respiratory therapist and a flight paramedic here in Colorado. It's kind of interesting to say that. I'm really excited that there's some people from out of state online with us today. So I have been an RT since 2004 and then a paramedic since 2011. And I went to EMT school right out of high school in 1998. So this has been something I love doing for my entire career. So I want to keep it nice and light tonight. This is a very serious time in our life, a very serious turn of events. So I want it to not be real serious. I want us to be able to joke a little bit because our jobs are really stressful right now. Feel free to send comments to Jeff or questions to Jeff anytime you guys need me to stop. It's not going to mess me up to have to stop at all. And then if you guys personally want to send me anything or you want to talk or anything like that, my email will be on here. It's beyondthebvm, no spaces, @gmail.com. And you can send me anything you need about your event, about any specific protocols you guys have. So we're not going to focus on any specific ventilator tonight because there's just too many to do that. And now with recent history and a lot of these companies stepping up, we'll probably have about 2 to 10 more kinds of ventilators that we didn't have before, like from Tesla and Dyson and CAE and some really cool companies stepping up to fill the need. So we're not going to focus on any certain ventilator. We're going to talk about the 2 big ventilator modes that we see. We're going to talk about these crashing patients when they come in, and then just how to keep you safe, how to keep your next patient safe, all those types of things. So if you have any specific questions to your team, your hospital, your facility, whatever that is, feel free to email me, and there'll be that email address on the screen again in a little bit. So here's the legal part that I have to do. So I am not paid by any ventilator company or any piece of equipment company that you see me showing a picture on here, and I don't endorse any specific piece of equipment. I have my favorites, I'm sure everybody else does, or what I've had my experiences with, and I'm happy to share those as well. So, and all my opinions are simply mine, so don't replace my opinions with any of your protocols or any of your guidelines. Unfortunately, we have to say that nowadays. So I operate under my physician advisors, and you will have to do the same. So please don't just do it because I said it was a great idea. Make sure that you guys have gone through the proper channels before you start implementing some different procedures and things like that. So, all right, so here's what we're gonna, kind of the flow for tonight, how it's gonna go. We're gonna talk about some PPE use. This is, I don't know that I'm gonna be able to shed a ton of light on this subject, simply because the CDC is coming out and the World Health Organization are coming out with new recommendations every day. I can't say if it's good, I can't say if it's bad. Every day we seem to hear about people not having enough PPE. We seem to hear about not needing to use as strict of PPE guidelines for certain types of patients. So we'll just have to kind of navigate that on a day-to-day basis as a community EMS hospital community together. So, but I can tell you the information that I know right now, working at a level 1 pediatric trauma center and also working at a level 2 trauma center up in Greeley as a flight paramedic. So I can share those things with you. We'll talk about the 2 most common ventilator modes. We're going to talk about volume control modes and pressure control modes. So most of the ventilators any of us are going to have access to are going to have those 2 types of things. And I'm even going to get a little more specific and tell you if this is completely new to you and you are someone who is just trying to figure out how to keep this patient alive until a transport team can get there. I'm going to even make it more specific and tell you 1 mode and 1 thing specifically to do. So, and then we're going to talk about how do you choose your settings? How do you decide what kind of tidal volume and respiratory rate and things like that? And what if those settings aren't working for you? Where do you go from there? And then we'll talk about end tidal monitoring. This is going to be probably some of the easiest ways you guys, either in the field or in these more rural facilities, and even in our busier facilities, because sometimes you're not going to have the staff, you're not going to have the resources to be able to be doing ABGs and BBGs and sending labs and all those types of things. So end tidal might be the only thing you have access to, and we can use it for a lot of different things. We'll talk about the big, bad, non-invasive ventilation right now. We'll talk about how we can do that safely. We'll talk about how we can safely BVM ventilate our patients, and then how we can, or if we should, add on nebs and things like that. So like I said, feel free to jump in anytime if you have a specific question about one of these. And then I'm just going to be really honest with you guys. We put this together kind of quickly because we know the need is out there for this education, and we want to share as much as possible. But I was literally working on this until 5:52 tonight. So I'm working overtime just like everybody else is. So forgive me if some things are not perfect on here like I normally like them to be. All right, so let's jump in. What kind of PPE is recommended for what we do? So we're specifically talking about our respiratory patients. For me, any type of respiratory patient at all, I'm going to use the top right picture. So I'm going to be in an N95, I'm going to have a face shield or goggles on, I'm going to have a gown and gloves on. If I can possibly find something to cover my hair, I will do that as well. And then if I'm going on a COVID positive, confirmed positive patient, I'll be in a PAPR. I will be in the whole thing, which is the picture on the bottom right. I think every facility is coming up with different recommendations. So when I go on a call, we have screening questions. And that seems to be pretty universal right now, as even 911 is screening people. So have you had contact? Do you have a fever? Do you have any of these symptoms? So if you don't have symptoms, how can EMS and ER nurses and things like that approach you? Anytime I'm doing a procedure that is cough-inducing, non-invasive ventilation or nebulizer, I'm going to be in the full PAPR. If I don't have access to my PAPR, you should be in the full N95 with a face shield and a hair cover, a gown, gloves, and shoe cover. And that's all this stuff that I've pulled off the CDC website. So that's current for what's going on right now. There's lots of interpretations to this. This is going to wax and wane depending on what kind of PPE you have. One of the things I've seen that I think is a good idea is maybe just wearing your PAPRs a lot more. So because they're plastic, I don't know about you, but I know we're talking about deconning our N95s and cleaning them. Doesn't give me warm fuzzies inside, but it's simply the way it is. But the PAPRs are plastic so that we can wipe them down. And so I've been wearing those a lot more and conserving our PPE, our N95s and our face shields and stuff like that, simply because this is just a more sustainable way for us to care for our patients right now. Now, can I wear that on the helicopter? No, I can't. I have to wear an N95 mask with my visor down. But we adjust to whatever circumstances that we're in right now. Jeff, do you see any questions from anybody about this right now?
From Heather Lang, is there going to be a way to get a copy of this presentation to share with colleagues? If not, do you mind if we record it? I will record it. It'll be downloadable on a shared drive. There's a question that says, our facility doesn't have inline suction. We are small. We have a Zoll vent. Is there any way to MacGyver inline suction?
There's not really a good way to MacGyver it. I will show you guys and talk about clamping the ET tube every time you do anything where you pop a patient off the ventilator. That is kind of way things are going anyway when we talked about patients that are PEEP dependent. So even more now, that is very much an important thing that we need to be doing now is to clamp our ET tubes. So I will, Heather, I'll definitely look and see if there's any other options, but I don't think there is right now. As far as MacGyvering them, most of the time you're just gonna have to pop them off, which is very unfortunate, I'm sorry. And then I can also make my PowerPoint presentation available to everybody if they need it. All right, so when we talk about protecting ourselves, number one, you know, BSI seen as safe from 25 years ago. literally almost said it every day of my life. How can we protect ourselves and how can we protect our patients next? So here's a couple pictures on here. We can provide a lot of things. People are getting really creative with this. And all it will tell you is just make sure you know what kind of bacterial filters you have. There's a lot of them out there. You need to make sure that it's a virucidal one that will take care of 99.9% of viruses. There's HMEs and there's HME filters. So you need to make sure that you have the right one and it just simply doesn't say HME. There's tons of these out there on the market. I'm sure that hopefully we're not going to have a shortage of them like everything else is eventually, but hopefully we will be able to keep up the need for this. So it's just important to look at which device you're using and which circuit you're using and where you're going to put it in line. Make sure that if you have a dual limb circuit like the patient or like the picture on the top left, now they kind of overkilled it with 3 of them. You don't have to do that. So think about when we talk to, there's some slides at the end about dead space and things like that. So normally these filters add between 20 and 30 cc's of dead space into your circuit. So if you have a patient who's in respiratory failure to begin with, their CO2s are going to be high. So you've possibly with 3 filters added almost 100 cc's of dead space. So if you're doing a low tidal volume strategy on a female that's my size, that's going to need somewhere around 300 cc's tidal volume, 100 cc's of that is going to be dead space. So these things, everything we do, every action has a reaction. So just keep that in mind. If you have a patient that you're like, all right, I put them on the vent, but their CO2 is going up. What is going on? They have a good rate. They have a sufficient tidal volume. Look at those exhaled tidal volumes. See if you're losing that somewhere and see if you up your tidal volume or respiratory rate or up all those things will affect your minute ventilation if you can start to decrease that patient's end tidal and their CO2 on their end tidal. So same thing when we talk about bagging patients. We've seen a lot of pictures. A lot of the EMS podcast groups that I follow have come out with some great ideas. The one I really like is EM Crit, and that's Scott Weingard. And there's some references and a connection and a link to him in the back of this, at the end of this. But he's the one I really like. They are part of a really big critical care ER ICU that I think they do a great job. So he's been putting out a lot of videos, a lot of pictures of ways to protect yourself. But that top middle picture, if you replace the tubing behind the filter and just put a BVM right there, that would be perfectly fine to do to be able to bag a patient. Same thing when you're talking about your non-invasive patient down there with your picture on the bottom. Make sure that, especially if you have a neb in line, and we'll talk a little bit more about that in a few minutes, make sure that you have your filter behind your nebulizer. And even in this picture, I like to put it a little bit farther back because no matter what, this filter is going to get soiled, is going to get wet. And you just can't, they can't guarantee the efficacy of it once that thing gets soaking wet. It's also going to increase resistance when your patient pulls and triggers the breath as well. So just a couple things to think about. I urge people to put their expiratory filters pretty far back in the circuit to be able to be closest to you because it's protecting you. That's what it is doing on the expiratory side. And also to keep it away from all the condensation that's happening closer to the patient's face. So these are just some pictures of places that I work and some that I've pulled out of other places, but just some visuals of what we've been doing just to keep things the way they need to be. So if you don't have a nebulizer in line, you want to make sure that your filter is behind your end tidal. Your end tidal needs to be the closest thing to the patient. This is a good example, this picture on the right. I'm not sure if you guys can see that. Ooh, let's go back one. Of our ET tube, and then the end tidal, and then the filter, and then there's a dual limb circuit. So you can put the filter right there before the Y, or you could put it after the Y on the exhalation side as well. Because if you wanted to have a nebulizer in line, that is where you're gonna want it to be. somewhere close to there. And then the picture in the middle is the Hamilton vent. So you have a dual limb circuit as well. So you need to have 2 filters. You need to have one on the inspiratory side, one on the expiratory side. Another thing you can do if you're trying to conserve filters, if you have, you're in a more rural facility, is you can put it right at the patient, like the picture next to it. But it's always a good idea. It's always been recommended to have filters right at the ventilator because you're protecting the ventilator. So the next time you put it on a patient, you're not infecting the next patient that goes in. So something to think about. I know in the transport world, these filters are have been new, and I don't know really why, because as a respiratory therapist, they haven't been new in my world and they haven't been new in my transport world. But when I've seen a lot of companies post a lot of pictures about their ventilators, you don't see filters in line. You hear a lot of things like there's always positive flow going through the circuit, things like that, but that is not 100% guarantee. And with a virus this strong, we do not want to be taking any sort of risks here to be passing this on. If you take, you know, if you fly a baby that, or if you fly an adult patient that is COVID positive, and then you go out on an RSV baby, you just don't want that kind of liability and that kind of ethical issue on your hands. So this is the way I've always set up my vents ever since I've been doing this back since 2004 and on my in my several different transport jobs. So that is has always been my platform with these filters. Even when we weren't having this COVID thing, I would walk into a transport company and be like, oh my God, nobody's using filters. Please, please, please use filters. And then the picture with just the ET tube and the BVM, there are 2 filters on there. That is not necessary, especially if you're trying to conserve filters. You can either put one right at the ET tube or on the exhalation side before that PEEP valve. In this setup, I think it might be easier to put it right at the ET tube just to make sure you're not messing with the efficacy of the PEEP valve and things like that, but you can get a little creative. You can put extension tubing that you see that comes extra in the vents a lot of times to make it side stream a little bit out of the way, so you don't have a lot of weight directly on the end of someone's ET tube and it's kind of off to the side like a lot of people like to do. You can get really creative, but if you guys have any questions about that, you can definitely send me pictures of the limited equipment you have, and I can see if I can help you out with those types of issues. Any questions or anything before we move on to ventilator modes?
I see a raised hand from Jessica. I don't know if that was the question that we had earlier or a new question.
Jessica, do you have a question?
Nope, she says no, thank you.
Okay. All right. So we're going to discuss tonight the 2 different modes of ventilation, volume control, pressure control. Now, every ventilator and every ventilator company comes up with a new special mode for either one of these things. They're called different things. You're going to see volume controlled called SIMV, VC+, PRVC. There's all sorts of ways to spin this, but you need to know the main thing you're controlling in that mode. So if you are in any type of volume mode and you know that you're controlling volume, that means that pressure is going to vary. So you can control that 300 cc's of tidal volume is going in, but you're not going to be able to control that it takes 52, a PIP or peak inspiratory pressure of 52 in order to push that in. So what that's simply going to tell you in that mode is that your patient has very poor compliance, or there's something from preventing that breath from easily disseminating into the lungs. So let's flip that. If you're in a pressure control mode, that means volume's going to vary. So a lot of people really love pressure control mode. I got to tell you, even in these bigger facilities, even on our neonates where we've traditionally seen pressure control kind of thrive, we're tending to move toward volume now because we know that as lung compliance dynamically changes, that you're going to be giving that same pressure, and sometimes as your lung compliance starts to go down, your volumes are going to start to go down, which is going to contribute to atelectasis. And if you're not watching that patient breath to breath, sometimes that could be going on for an hour before you know. And we know that patients that are hypoventilated have a higher risk for ventilator-associated pneumonias, atelectasis, ARDS, those types of things. So we're just kind of seeing the limitations in a lot of our pressure modes. It doesn't mean I don't use it when I have trouble ventilating kids. I have still gone into pressure modes, but I am watching that ventilator breath to breath to breath. And so if that is not a luxury you're going to have because you're one of 4 people in an ER with 20 people that you need to see and 1 person's on the vent, I think your safest option, if I'm going to have to pick one, someone's got a gun to my head, pick a mode. I think any type of volume guarantee mode is what is best for these types of patients. So what you need to know is what yours is called on your ventilator. Some of them are simply called volume control. Then you're going to have an option to do like SIMV, which is synchronized intermittent mandatory ventilation, which is also a volume mode. PRVC, pressure regulated volume control, is also a volume control mode. So all these ventilator companies just take it up a notch and make it a little more confusing, but you just need to break it down. Are you controlling volume or are you controlling pressure? And so if you're controlling one, the other one's going to vary. That's what you need to pay attention to. So you can see with this chart on here that this is going to be able to show you what you control, what you get to mess with, how much the patient gets to contribute, things like that. So when we break it down, when we're going to do a straight volume control mode, which most of our ventilators allow us to at least have the patient participate a little bit more, strict volume control modes that don't give you the luxury of SIMV or pressure support or any of those types of things really lock out your patient. So when you set a tidal volume of 400 on there and a rate of 12, your patient will breathe 12 times with a tidal volume of 400, and then your patient, when they decide to take their own breath, will be given 400 no matter what. If they want to pull 600, 800, whatever that is, if they decide to take a big sigh breath, they're going to be locked out by the vent. So a patient that is awake and breathing with you on the ventilator, this can be very uncomfortable for them. So if you have a mode that will allow you, such as SIMV, which will allow pressure support, that's what I would tell you to go with as far as which volume control mode you're going to want to do. With SIMV, it means that same thing, you're going to set your tidal volume of 400, your rate of 12, and your patient's going to be guaranteed to get 400 12 times. And then you set a pressure support, and that is not a volume but a pressure, which means there's always flow circulating through your circuit. So your patient never has to, when they trigger a breath, pull all the way back through the circuit, all the way to the ventilator. It's always very responsive with flow going right toward the tip of the ET tube. So when they trigger a breath, you'll give them a little extra pressure and they'll be able to pull whatever volume they like. So if you have a patient that you are not able to sedate, maybe because of blood pressure problems or during this time, maybe manpower problems, then this is the best mode to be on. Your patient can participate a lot. And then when we talk about PRVC, so pressure regulated volume control, we talk about you're going to set your volume, you're going to set your respiratory rate, you're going to set all the things you normally set, but that ventilator is going to specifically try every single breath to give that same volume but with less pressure. It's more of a protective strategy. But here's the problem that happens. So number one, we found that kids don't like PRVC. And the more sick your patient is, the less they tend to like it in your adult population as well. So we're finding that so at one breath, it takes 30 centimeters of water pressure to deliver whatever tidal volume you set. Then the next breath, it takes only 23. And then the next breath, it takes 40. Well, that is all has to do that centimeters of water pressure that it's taking to deliver that breath. That is transducing to what kind of interthoracic pressure is going on. So number one, most of these respiratory patients that we're seeing are having some sort of cardiopulmonary collapse as well. So they're having trouble regulating their blood pressure. Well, what happens when your lungs are exerting different pressures every single time you breathe, that your left ventricle, your heart, can't figure out how hard it needs to pump every time in order to get what kind of cardiac output you need to have. So then your heart tends to get a little irritated as well. So that's just what we've seen in our critical care environment, kind of what is emerging with those types of ventilator modes. So just something to think about. Hold on one second. No, I don't see anything about polls on mine. All right, so let's break these down a little bit more. I'm going to come back to this slide in just a second. So we talked about SIMV. This is the one I would recommend if you have a ventilator that will allow you to set a volume, set a rate, set an I time, and also set a pressure support. This is the mode that I recommend. You're going to get a breath guarantee, but the patient is also going to be able to take breaths on their own. They're going to get a set amount of tidal volume and a set amount of breaths, but your patient will be able to synchronize a lot better. And then with the pressure support breaths, they'll be able to take however much volume they need. And this can also help with, like we talked about the PRVC, is that your patient isn't having to work so hard and isn't so anxiety ridden, so it can help a lot reduce the cardiac workload that your patient is going to need. PRVC, if this is something we talked a little bit about this is almost exactly the same. So you're going to set your I time, you're going to set your tidal volume, you're going to set your rate. Sorry if I forgot to say, you're going to always set your FiO2 as well. You're also going to be able to have pressure support on this mode, but you're not going to be able to set what pressure it's regulating. It's just going to do it on its own. And here's what I'll just say is that I went to school for a long time, and I feel like there's a limit to how smart these ventilators can be. So you need to mix a really good ventilator with a really good therapist or nurse or paramedic or whatever you happen to be, doctor, PA. I don't want to just turn all control over to the ventilator, and that's kind of what PRVC does. It's going to change every breath, just what it thinks the patient's doing. But it doesn't maybe know that the patient had a cardiac event. If you're going on a STEMI or something like that, your heart, you don't want to mess with the cardiac output and that whole Starling's law and things like that. You really don't want to mess with that after a STEMI by putting your patient on PRVC. So that's been my experience. That's what I feel. A lot of my friends at Medevac have kind of witnessed the same thing, that PRVC was just not the life-saving mode that it was really deemed. But if that's what you have, it's still not going to hurt your COVID patient, because that's kind of what we're discussing here. But we also need to keep in mind that a lot of these patients have some pretty high comorbidities. So, all right, let's go back and talk about volume. So how are you going to pick what you want? All of our COVID patients, all of our patients in true respiratory failure with ARDS should always be ventilated with the ARDS-NET protocol. Any of the big websites that I've referenced here through EMCrit and IAMed and things like that, this is really what's working for these patients right now. This is really kind of where all of our ventilation should be, and this is not a new theory, especially for critical care medicine and respiratory therapists. This is what we've been doing for a really long time. It's just starting to flow out into the pre-hospital world as well now. So why we like volume control ventilation? We said that your set tidal volume, you're going to be able to do that. But what if you have a patient that is full of secretions and is having a CHF exacerbation because they're COVID positive and they're hypoxic? You're not going to be able to push those bigger tidal volumes in that you're used to. So this is really advocating for that between 6 and 8 cc's per kilo. And depending on your protocol and guidelines, that is how you're going to pick that. I always shoot on my bigger patients for 8 cc's per kilo. I want to try and get the volume in there so I don't have to up their rate as much as I need to. If they can't tolerate 8 cc's, I will start dropping down from there. My babies, my small babies, like less than a year old, I like to shoot for 6 cc's per kilo. and then kind of go up or down from there based on what their exhale tidal volumes are coming back. But if you are shooting for 8 cc's per kilo and your patient just isn't tolerating it, which means you're getting high pressure alarms on your vent. So they'll be hitting if you set your peak inspiratory alarm at 40, it means they're hitting 40 every time. And once you hit that 40, a lot of people don't think about this, but it won't continue to give the breath. Your ventilator will cycle into exhalation. So if your ventilator has only given 50% of the tidal volume that you've set, and then it cycles into exhalation, your patient will be chronically underventilated over and over and over again. So you need to be really responsive to those alarms. And I have a whole slide in here about how to set the alarms and what to pay attention to with that kind of thing. So the one thing I like to look at when we talk about our ARDSNet protocol is there needs to be 3 things that happen. So I hear a lot of people talk about ARDS and they just talk about high PEEP, high PEEP, high PEEP. Yes, it is high PEEP. And one thing that we found with these patients, especially our COVID patients, is that they are responsive to high PEEP. But the ARDSNet protocol itself is 3 different things. So it's picking the correct tidal volume between your 6 and 8 cc's per kilo. Don't be afraid to go down to 6 if that's what you need. But if you go down to 6 cc's per kilo, you've now messed with the total minute ventilation. So if there's this whole equation, so it's respiratory rate times tidal volume equals minute ventilation. So you need to think about you're trying to maintain a certain minute ventilation. For you and me, it's right around 6 to 8 liters per minute. So if you have a sick patient that has a higher demand, you're going to be somewhere closer to 10. So you need to really figure out, if I'm dropping the tidal volume, but I still need to meet this 10 liters per minute, what has to go up or down in that equation? So your respiratory rate then needs to go up. So what I see a lot of times is people picking 6 cc's per kilo, a PEEP of 10, and a rate of 12. Rate of 12 should not happen when we're on an ARDSNet protocol. You need to have a lower tidal volume, a faster respiratory rate than normal, and a higher PEEP than normal. So look at this table on here and look at when I walk into facilities, I see patients that are really sick, and I see them on a PEEP of 5 or 6 and 100%. And what really should have been happening here is an incremental increase, because you can't diffuse oxygen down through underventilated lungs, through atelectasis, through CHF, through boogers, through pneumonia. You can't just by dumping more and more oxygen in, that's not going to help. What are you doing with that ventilator? Push that past those obstructions. And a correct tidal volume, respiratory rate, and then PEEP is going to be your big deal. So a lot of people will just crank that right on up to 100%. That's not really going to be helpful if you have a big layer of pneumonia sitting down on your alveolar capillary membrane. You're really going to need PEEP to do that. So what hopefully this urges people to do is to be more aggressive with their PEEP strategies. So you and I maintain a certain amount of pressure in our lungs. We don't fully exhale everything. So they're theorizing that we have somewhere between 3 and 5 of PEEP, but which really just translate to a certain amount of volume that we never exhale out of our lungs to keep our lungs inflated. So when you put a piece of plastic through their cords, you've now equalized the outer pressure with the inner pressure, and now they have no PEEP, and their lungs will just collapse. So that is why we do pre-ox, that is why we do our nitrogen washouts, that is why we do CPAP, things like that before we ventilate people, to prevent that big collapse that happens. So make sure you think about that. Not only when you put a patient on the ventilator are you going to give them 5 back, because that's what they always have. You're going to need to give them more. They're sick. 5 of PEEP isn't going to do it for these patients. Most likely 10 of PEEP is not going to do it for these patients, but you need to be moving up quickly, especially if you're on 100%, because in the ICU world, we would rather see a patient on 10 or 12 of PEEP and 70%, than 100% and 15 a PEEP for a really long time. So you can equalize those things and start to decrease the amount of oxygen you give and the oxygen toxicity that might happen a week into their ICU stay. Now, let me reiterate that ICU or oxygen toxicity is not going to be a big deal for us in the field. I've never really worried about it a whole lot because we're with our patients for such a short time. It's really something that the ICU needs to care about, but it's something to think about as well, that you're going to better use your oxygen that you're giving your patient if you give them PEEP to push it in. So that's what you need to think about. So 3 things for your ARDS-NET: low tidal volume strategy, faster respiratory rate, high PEEP. All 3 things, if you don't do all 3, you're not doing an ARDS-NET protocol. So in all of our volume control ventilation, you're gonna pick 8 or 6 cc's per kilo, whatever you're gonna do. You're gonna pick your respiratory rate. So remember, if you decide to pick 6 cc's per kilo, your respiratory rate's gonna be faster. There's lots of crazy formulas online, feel free to look it up. I don't do a ton of calculations as far as these go. I kind of just set it. If I'm picking a lower tidal volume strategy for my adults, I start somewhere around a rate of 20 and then go up or down from there. And then you're gonna set your inspiratory time. So this is going to depend on what kind of compliance your patient has. If you pick a very fast inspiratory time, so something less than 1 second, if you pick 0.8, that means that the ventilator is gonna have that time frame to push in the volume that you've asked it to. If your patient has poor compliance, the ventilator is gonna have to push real hard, and it's gonna be really hard to do that. So pick some longer tidal volume or I times, or just your normal I time of 1 in the beginning, and go up or down from there based on their compliance and what they can handle. And then there, as you can see on the left-hand side, is your respiratory rate times your minute volume, or times your tidal volume gives you your minute volume, something to always keep in the back of your head. And then how are you going to institute that ARDS-NET protocol when we get there? So hopefully you've picked your 8 cc's per kilo, and then you're going to set your respiratory rate a little faster, double fast for kids. Set your I time. A lot of people ask, like, what I time do you use? I can tell you, if a lot of vents will default, especially if you have a pediatric patient, they will default to very fast I times. So if you have an RSV baby that is also COVID positive, and then you set a really fast I time, like 0.4, that is a very fast I time for a patient with really poor compliance and a lot of boogers in their chest. It's just not going to go well for you. So think about the lowest I would go in a pre-hospital environment is half of what you would give an adult, so 0.5, and I'm somewhere around 0.4 to 0.5 on neonates. So if you're really in the pediatric population, you're a little bit above there. You're somewhere between 0.5 and 0.7, and then above that for your adult population. Any questions? That was kind of a lot.
They seem to be answering their own questions back and forth about ideal body weight.
Yes. Yes. And since I have it in this whole screen, I can't see the chat that's happening. I can see some people that are online. And I can see my toolbar at the top, but I can't see the chat that's happening. So let me know if I need to jump in on something. So here, this slide just shows a little bit of that recommendation. So you're gonna pick your volume control mode. Like I said, if you're gonna back me into a corner and say, Melissa, pick a mode for everybody, some type of volume control mode, but with a lower tidal volume strategy. So most of your vents, you're gonna have to pick a tidal volume, you're gonna have to pick a respiratory rate, you're gonna have to pick an I time. If you pick a vent or a type of mode that allows you to have pressure support, you'll be able to pick that. You'll pick a PEEP and you'll pick an FiO2. Sometimes you'll even pick sensitivity, which has to do with how easy it is for your patient to trigger the ventilator. Just make sure you know your vent, because if someone has messed with that and your patient trigger is really high, your patient is going to struggle and struggle and struggle the whole time. So just making sure you know your equipment, and if you are in a rural facility or if you're having to put patients on vents and you're not normally used to that, make sure that you have access to, either if you're transferring to a center, if you have access to talk to an RT there, or if you have access to talk to your ventilator rep. Those are important numbers to have close by now. I know that if you were to transfer a patient to Children's, you can always talk to the attending, whichever, if you're going to the neonatal ICU or the pediatric ICU. And then I've always been available as a transport team on the way there to help triage your patient and like get them stable, or at least get them set up on the ventilator before I get there. So just kind of use your resources if you're transferring to a bigger center. Even your transport teams are willing to take phone calls and things like that. So even if I'm on my way to see you, if you were to transfer into my dispatch center, there's 2 other teams on for Children's, and you'd be able to speak to one of the other teams that would help you get that baby stable until I get there. And that is a resource that a lot of teams have, a lot of dispatch centers have. So just think about your resources there.
Melissa?
Yeah.
Yeah, from Icarus Paramedic to everyone on the chat line. He put a couple of URLs up here. He says, I'd strongly suggest downloading the IBW ideal body weight chart and laminate it on the opposite side of the ARDSNet chart. And then he gave some URLs there.
Yep, absolutely. So yeah, you have to pick your 6 to 8 cc's per kilo. So if you have a 500-pound patient, their lungs are not equipped to take care of 500 pounds. Their lungs didn't grow with their body like that. So their lungs are still a normal size. So if you did it just off their body weight, you would overventilate them like nobody's business. So make sure when you're picking these for 6 to 8 cc's per kilo that it is always by an ideal body weight chart. And anytime I do like write a protocol for people and that's what they're using, same thing like they were saying, there's always an ideal body weight chart either attached to the ventilator or within that bag that they use to set up their ventilator, easy for them to kind of calculate that stuff out, male versus female. So yeah, good point. Thank you for adding that. All right. So what if you, so we talked about our big favorite vent mode that we're thinking about if you're kind of backed into a corner. But what if that simply isn't working? What if your patient's lungs are just absolutely trashed? What if they have COPD or emphysema and they've been at home sick for a week and you know, they're COVID positive and now they come into the ED and you're having to intubate them emergently? Side note, emergently, when I say that, because of the amount of PPE that is needed to care for these type of patients, it's been discouraged to do anything on an emergent basis. So, you know, if someone collapses in the waiting room or outside your ED bay or something like that, please make sure you still do what's right and put on your proper PE before you go in there. There's lots of really cool companies out there right now that are coming up with these cool boxes to put over patient, clear boxes to be able to intubate through and things like that. I've seen different podcasters using like big clear bags over there. I mean, it seems a little barbaric, but we're just in a time that none of us are really used to. I've always intubated with a mask on just because once the first time, you know, a patient barfs when you're intubating them, that's the last time you're ever going to do that. So intubating with goggles and a mask is pretty normal for me, but it would take a lot of practice for me to intubate through a big clear box with a hole for your arms to go in, but it's pretty cool to do. So just make sure that you are taking care of yourself before you try to emergently do anything. All right, so what do we know about pressure? We talked about if you can only control one thing at a time. So if you're in a pressure control mode, you can only control pressure, which means volume will vary. So when you pick a pressure mode, it will be translated to centimeters of water pressure. So there's been lots of things going around about what is going to cause barotrauma, volutrauma, things like that. There's been a big emphasis on plateau pressures and driving pressure and things like that. We can discuss a little bit more about that when we do like an advanced ventilator class and then in the next couple weeks. But what I will tell you is that if you have a very sick patient that will not tolerate volume ventilation, the amount of pressure you're going to have to put in them is going to make you uncomfortable, because what we hear is you don't want plateaus greater than 30. Well, if you're failing 6 cc's per kilo, which means your lungs are so sick, so tight, and so uncompliant that it can't even tolerate 6 cc's per kilo, The amount of pressure control, amount of pressure you're gonna have to push in their chest just to give some type of decent ventilation is more than you're used to. So what I see a lot of people do, like normal, if you were just gonna put a baby on a vent that was a seizure baby and was just maybe over medicated or needed to be medicated that much to stop their seizure, they don't have any lung problems. A good starting place is 20/5. 20/5 is not going to work for a patient that lungs are trashed like that. It's just not going to work. So think about where your pressure alarm was set when you were doing volume control. So mine is always set 5 to 10 above. So normally it's going to be somewhere around 35 or 40, which means when you pick your pressure control number, that is a good place to start. So if you were going, then you would be 40 over whatever, you know, so then you have to start looking at things like, is your ventilator PEEP compensated or not? And here's where we lose people because the ventilator companies have made it kind of confusing. Some ventilators know and will calculate for you. So if you wanted a peak pressure of 40 and you had a PEEP of 10, the ventilator would only give 30 because your baseline is always 10. So it always go 30 above that, and that would give you a total pressure of 40. Some ventilators don't do that. So if you truly wanted a pressure of 40 and you have a PEEP of 10, you are going to have to set that at 30 and then look at your total peak inspiratory pressure. And if you have a vent like that and you're confused by it, feel free to text me or send me an email and we can kind of talk through that again a little bit. So just remember that if you are having to pick pressure control because your patient is that sick and failed volume, you're gonna be on some really high pressures. And that's okay, that's what they need right now. They're probably gonna need a lot of other things if that's what they need. They're probably gonna need to be prone. We've seen a lot about prone ventilation. That's not new in the critical care world either, much like the ARDSNet protocol. The sicker your patients are, flipping them on their stomach and giving you some more surface area to ventilate and moving those secretions around so they're not becoming concrete right down in your alveolar capillary bed is a great thing to do. Easy to do for kids and babies, you just flip them around. Hard to do for adults, hard to do in the EMS environment. But we are starting to see that sometimes that's the only way to transport a patient. You're not going to be able to oxygenate them on their back. You're going to have to do it on their stomach. So this is one of those types of scenarios that if you are in a rural facility and your patient has failed volume control ventilation, you've had to go over to pressure control and you're on 30/12, so you have a peak inspiratory pressure of 42, and your patient is still not oxygenating and still not ventilating, your end tidals are through the roof, your blood gases are bad, your patient's blood pressure is not great, they're tachycardic, all these things, you know your patient's in bad shape. This is one of those times when talking to the ICU that you're sending to or the referring or the receiving facility or your transport team, this is one of the times where that might be something that they suggest is, you know, let's try flipping them on their stomach. In the ICU, this is something you do. You try a couple different ventilators, high frequency ventilators, that type of thing, but that's not an option while we're transporting. So something to keep in the back of your mind, especially with these COVID patients, we're finding that moving them around and increasing the amount of surface area that we have to ventilate is really helpful. All right, so pressure control. So think about this, if you put a pressure control of 40 on there and you watch their exhale tidal volumes and you've already calculated that out of what 6 cc's per kilo should be, so you know that ideally this patient for 6 cc's per kilo should be returning 320, let's say, and you look at your exhale tidal volumes and your patient is returning 125 with a pressure of 40 on there. Is that good? Is that bad? It's bad. So that is your way to gauge how much pressure to give. You can't control the volume, but if you give more pressure, you're going to give more volume. But what I want you to think about is that this number down here is your PEEP. This number up here is your peak inspiratory pressure, your pressure control number. You don't have to just increase this. Feel free to increase your PEEP and increase your pressure control number at the same time. Remember, a lot of people think it's just purely for oxygenation. At this point in this disease, PEEP is contributing to ventilation as well. It's allowing those trapped gases, the trapped CO2, it's stenting your airways open, it's driving in oxygen and allowing that CO2 to exhale. So it's contributing to ventilation as well. It's not just something for oxygenation, it's contributing to ventilation as well. So think about those two things together. If you need to up your volume because your patient's not getting enough, feel free to up that pressure control number, but feel free to up your PEEP a little bit with it. Do those incrementally together. Think about your ARDSNet protocol, because you can still do an ARDSNet protocol when you're in pressure control. So you do want to up their volume, but you want to up their PEEP as well to make those two kind of harmoniously work together. So as those things change, meaning as your patient's lung compliance changes, those volumes are going to change. So if your patient gets more and more stiff, their lungs are getting dry, those secretions are starting to cement up in there, you're going to be giving that pressure control, but the volume will be less and less and less every time. So you'll be hypoventilating those patients. So that's why if you're in a pressure control mode, you really need to pay very close attention to your patients because things are changing from breath to breath. Pressure control mode, you will, instead of setting a volume, you'll set your pressure, you'll set a respiratory rate, you'll set an I time. Most likely you'll set a pressure support setting, so when they take their spontaneous breaths, they can kind of dictate that on their own. You'll set your PEEP, you'll set your FiO2, and you'll set your sensitivity as well. Any questions about pressure control?
I do not see any.
Okay. So these are the two. When I was asked to do this, I thought I need to simplify this a little bit because the amount of modes, and you can just go on and on and on. These are the two big ones that I think are a great place to start. And like I said, even for me in a critical care environment, I'm going to try and stay in a volume control mode as much as I possibly can and just start decreasing my tidal volume and upping my respiratory rate and my PEEP in order to get the volume that I need and get the ventilation that I need. So these are the two big ones that I'm pushing for you guys out there. So we're going to talk about a couple of other things, but if you guys want to come back or have any questions about the two things that we talked about, feel free to bring up any questions. All right, so let's talk about our ventilator alarms. This, as an RT, obviously, ventilator alarms are really important to me. I need to know why that ventilator is alarming. The most I hear all the time, and it breaks my heart when I hear people say the most important button on this ventilator is the alarm silence button. It's not. Please do not, in the EMS environment or the emergency department, just silence a ventilator alarm without knowing why. So here's a little breakdown of ways of what could be happening with your patient and those high priority alarms. Your high pressure alarm. So your vent is trying to push a certain tidal volume or a certain pressure in, and it's not able to do that. So what I tell you is to start at the patient and work your way backwards. So if you start at the end of your ET tube, what could be happening down there is a compliance issue. Secondly, what can be happening down there is secretions. So for compliance issue, you're going to have to mess with the ventilator. For secretions, you're going to have to suction your airway out. So then move up your ventilator. What could then happen from there? Inside your oral pharynx, your patient could be biting or could be awake, or your bite block has moved, or your ET tube is bent over and kinked. So make sure those things aren't happening with your ET tube. Move out from there. There could be kinks anywhere in that tubing, from your ET tube all the way back to your ventilator. There could be, I've had prams roll in and roll over them, and you don't know for a few seconds that something's happening. When you're loading in the helicopter, things get pinched really easily, in and out of CT scan, x-ray, those types of things. So start at the patient, because you're going to want to deal with what's going on with the patient first, and then work your way backwards to why that patient is high pressuring. So you can see on there the secretions. So we're going to suction, kinking, we're going to sedate our patient, or fix if it's kinked because there's too much weight on there and it's pulling to the side. We're going to fix that. Biting, we're going to fix. Patient coughing or gagging or trying to talk. So if they're coughing, please don't sedate them without checking that they need to be suctioned first, or gagging, make sure that your ET tube is in the correct place. That is one of the things that can be one of the only indicators that your ET tube has migrated down past your carina and into like your right lung, your right bronchus, is that all of a sudden now you're trying to give volume that you've calculated for 2 lungs only into 1 lung. So that's not great either. So when you're talking about looking on your way out and biting, you need to make sure your ET tube is in the same place that you left it and where you want it. Your low pressure alarm means that your vent is not connected or your ET tube's not in place. And vent tubing not connected, you can then break that down into there's a crack in your circuit, there's a crack in your filter. I have an inspiratory and an expiratory line plus 2 lines that measure things at the ET tube. So there's 4 lengths of tubing that I have to check when I have a low pressure alarm, and I've determined, number 1, that my ET tube is still in. Number 2, when you look at all the big connections and everything's connected, then you have to start looking for all the little stuff. So, but your 2 big ones means that, and the vents will pop off. That's not, just try and do your best to package your patient so you're minimizing those types of things. And then there's some other high respiratory rates, low exhaled tidal volumes, things like that. I like the low exhaled tidal volume alarm, especially when I'm in a pressure control mode, because if I get busy in the helicopter and you're mixing drips and you're doing whatever, you're making your phone call into the ER, when that starts to go off, you know that compliance is starting to go down, and you're going to get a real quick indicator that this is where that you need to start messing with these things. So my take on the ventilators and on the pressure alarms and your low pressure alarm is always that these things make me smarter. This vent is very smart. Me and this vent together, you and this vent together, working together is great for the patient. So use your vent for what it's good at, and it's good at these things. So don't just silence it and move on. Make sure you are truly troubleshooting those types of things. All right, when to stop. So a lot of people say, you know, I've done all these things that you've asked me to, but the patient, I just cannot get this ventilator to stop alarming. And depending why it's alarming, you know, if it's a constant high pressure, then the vent just might not be able to ventilate that patient with such poor compliance. You may have to do it with a bag valve mask. There's a picture on here that portrays a really good way that I got off EM Crit. To bag your patient with a PEEP valve in line, and also have your bacterial filter in there so that you're protecting yourself and your fellow people that are in there resuscitating with you. But when your patient is near arrest, and I was reading some CDC guidelines and a couple other guidelines, and they're talking about even with cardiac arrest patients, because of the likelihood of us getting infected when we pop our patients on and off the vent, that they're even talking about trying to leave your patient on the vent while you're doing CPR. I've tried to do this several times. It's really rough. Whoever is doing CPR really has to kind of pay attention to the ventilator, because you're going to have to kind of time those things just like you did the old school CPR and stuff like that. So you really have to time those things in order to not overwhelm the vent and get those high pressure alarms continuing. But those have been some of the recommendations from the CDC, is to try and keep your patient on the ventilator while you're resuscitating during CPR. If you cannot though, please clamp your ET tube. So before you disconnect the ventilator, pause the ventilator, clamp your ET tube, and then put them on the BVM, then unclamp, then you can start bagging. Number 1, that's going to keep the recruitment that you have, and you're not going to lose all your PEEP. Number 2, you're going to decrease your chances of being infected. We've talked about this for a long time, even with our sicker pneumonia patients. I don't want that stuff flying around in that little tiny box I fly in. I cannot get 6 feet away from anybody in that helicopter. So clamping an ET tube is something I do pretty frequently anytime I'm moving in and out to pop patients off if I have to do that.
Melissa.
Clear why your alarms, why you can't clear your alarms. These are machines, they're not perfect. Sometimes they're gonna alarm and you're not gonna be able to clear it, and the alarm is not gonna be accurate. Your vent is gonna fail. So just make sure you're good troubleshooting. And like I said, you can even print out that sheet that says how to troubleshoot those alarms. If you've done all those things and you can't clear the alarm still, then take them off and bag them or put them on a new vent, and that vent might just be dysfunctional.
Melissa?
Yep.
A question on the chat box. Heather Lang, can you discuss what measurable aspects we can look at to determine if we need to change tidal volume versus PEEP versus respiratory rate, i.e. end tidal CO2 values? Specifically, what can we see in the field, not ABGs?
Yeah. So unfortunately, you're kind of relying on your SpO2 and your end tidal CO2s. Hopefully, if you're doing like an interfacility transport, you can get even a VBG drawn in order to correlate, because here's the problem with the end tidals. So they're great in many circumstances. When they're not great is when your patient has a ventilation to perfusion or a VQ mismatch. That is almost always these COVID patients, and especially our pneumonia and ARDS patients. So what you have is you're dumping in appropriate tidal volume, appropriate oxygen, and your body's returning CO2, but there's a disconnect. Your lungs are full of fluid, or they're full of PEEP, they're full of excess pressure, things like that. And those two interfaces are not happening in order for diffusion to take place. So what you're gonna have is an unreliable CO2 number. It's not going to be indicative of what is actually in their blood. It's just gonna be indicative of what's left over in the upper part of their lungs where dead space ventilation is taking place. So I'm always really hesitant to use end tidal unless I've pulled an ABG or a VBG to correlate it with. As far as when to change with your tidal volume, that's all gonna have to do with your ventilation and your end tidal CO2. So if your end tidal is going up, you need to either give more tidal volume or a faster respiratory rate. If your end tidal is going down, your patient is either breathing too fast, and that could, even if you're not breathing very much for the patient, it could be because they're under sedated and they're just huffing and puffing away. Their brain is hypoxic. That's what it's going to tell them to do. And then, or there is too much tidal volume. So that can happen when you're bagging really often. You can see people bag for 2-3 minutes and not pay attention, and you had an end tidal that was 40 and now it's 20. So it's just most likely too much tidal volume or too fast of a respiratory rate. As far as when to give when to mess with your PEEP, is going to be driven by your SpO2. It can also be driven about the fact that maybe you're not comfortable going up on your tidal volume anymore. Maybe you are, you're bagging someone and you're already somewhere close to 50. And you're only on 10 a PEEP. Maybe I would dial that PEEP valve up a little bit to help increase the amount of good ventilation that you're getting in there and functional ventilation, and then you might be able to dial down on your peak inspiratory pressure a little bit. Did that help at all, Heather?
Yes, thanks.
Okay. And if you have any more specific, feel free to email me after this if I missed talking about any of those things. And all right, so when you have to pop our patients off, remember in this type of environment right now, just make sure you have your expiratory filter on there where you need it to go to prevent it from that exhaled gas that comes out of that BVM into the atmosphere that you're in. Make sure that it's correctly placed on there. All right, so we just talked about end tidal, and I wanted to specifically talk a little bit more about it because most likely, like you said, Heather, you don't have access to the ABG or even the VBG, or like even in these rural facilities, you just don't have the manpower or time to do these types of things. So this can be a good way for you guys to titrate your settings. So a good thing to know is if you see the picture on my screen, it's to the left. But of the cannula, the nasal cannula that you can do, that's a great thing to put on before you intubate somebody, so you can know where you're kind of starting. And that can stay on, even that can stay on while you're intubating, unless you're doing a high flow nasal cannula for your pre-oxygenation or something like that. But I often put my end tidal on the BVM, so even the first breath, I'm going to confirm with listening to their breath sounds, but also I want to see immediately and my end tidal start rising and start working on my monitor, so that I know immediately. Because even 4 or 5 breaths and you with a tube that's in your stomach, I mean, that increases your chances of your patient's chances of vomiting by a lot. And then you've taken a really sick COVID patient and now they have an aspiration on top of that. It's just not a great opportunity. So anytime you can decrease your chances of bagging a bad tube is really important. But that way you kind of know where you're beginning. You knew that before your patient went on, their end titles were in the 70s or 80s. Now you're going to put them on the ventilator, and then you can titrate how those things go. What we know is that a normal end tidal for our patients is somewhere between 32 and 48, depending on what you look at. But I wouldn't look for that perfect number because, especially if you can't correlate it, I would look for a range. So if you were at 75 before you intubated and now you you're stable on the vent and you're somewhere in the 50s, that's a pretty good change. If you change even more down, all the way down into the 30s, that's a big change in end tidal. All that has to do with perfusion in your brain as well. So depending on if you hyper or hypoventilate, it can cause vasoconstriction and vasodilation. So you don't want to change those in rapid fashion because you'll decrease the amount of oxygen your brain will have readily available. So just something to think about. If they're in the 70s, we don't need to slam them down into the 30s. Feel free to do a rapid or a gradual decrease or increase in their respiratory rate to get them somewhere close to where you want them to be. And just to make sure everybody knows how this end tidal works, a lot of people see that end tidal waveform and they think, oh, okay, that's your, that is the same as like your pulse ox going up and down. And it's a little bit different. You can see in the bottom there that your end tidal reading is happening at the end of exhalation. And we'll look at some odd end tidal readings here so that we can kind of troubleshoot what kind of end tidal readings you have. But make sure that this is a pretty normal looking end tidal waveform. Make sure you know, like you look at phase 1 at the beginning and phase 1 at the end, you want to compare those and make sure that you're always going back down to that same baseline. If you're not, you need to think about that your patient's retaining some CO2 and retaining some volume in there. If you look at how that waveform goes, if your waveform is steadily decreasing in the height, you are probably headed toward some sort of shock and might be headed toward a full arrest. So these are really helpful, and this is what I like end tidal for. I like end tidal to know really quickly on in and out, your moves in and out places, either for x-ray or CT scan, in and out of the rig, in and out of the helicopter, those types of things. I like that you can see immediately, you know where your tube is. I don't necessarily care all the time about the number, but I care to know all the time that my tube is good. And then I like to know things like that. I can start to see if my patient's breath stacking, if my patient, how that plateau is changing, the shape of that plateau, how that's changing, what's going on with their disease process. Same thing with that baseline. If that baseline starts to come up, my patient's breath stacking, or could just be retaining CO2. When I see that baseline go up, and this is something when you're talking about like how do you know in the back of the ambulance, when you have a patient like that, like number one, you'll probably start to see more of a shark fin waveform, so not necessarily the full-blown asthmatic, but you have a patient that has airways that are tightening and being irritated and you're not being able to exhale enough CO2. So you're gonna get more of an increase, not really a plateau, but more of an increase, and then you're not returning to baseline. So your patient's starting to retain CO2. That's a patient for me that I would try a little more PEEP on, because if they're air trapping, that's what they're going to need to stent those airways open. So that's what I'd be thinking about if I saw that type of patient. So this is just a good picture to let you see. This is a great waveform to let you know. So you can see that we see phase 1 is nice and low at baseline, and I look at phase 1 on the other side. It went back to baseline where it needed to go. But look how sharp. This should really be a slower increase, but that rise to end exhalation is really sharp. So that patient is really working pretty hard, might have a lot of compliance issues or have a forced exhalation. And that is what you can see on there as well when you see that kind of sawtooth pattern. And there, that is a patient that has different airway trappings going on. It could be either from the amount of secretion. So I think with this, it's more going to be a secretion problem, meaning that it's trying to dump CO2 out, but that oscillating waveform has to do with trying to get around all those secretions and those airways that are starting to collapse. It can be, your patient can be forcing that exhale and trying to cough. So just watch those types of things. Another thing you can see that looks just like this waveform is if your patient is reacting to the vibration. So I haven't seen it so much in the ground ambulances as I have in the aircraft as far as the vibration goes. So if you suction your patient, you're not having compliance issues, your peak pressures on your vent are really good, your patient looks comfortable, but that is what is happening. Try and move your tubing and not have it in contact with the aircraft, with the ambulance floor, things like that are ways to troubleshoot that. So here are some different waveforms that we talked about. We talked about that one on the top left-hand corner has to do with shock. So you see that you have a nice tall waveform, but if you look at it over a period of time, which is really what N-tidal is great for as a trend, that you can see that that patient's starting to decrease their perfusion. So they're starting to go into a shock state. Underneath of it, your hypoxia due to asthma, that's your shark fin waveform that you're kind of used to seeing. You'll see it even worse when you have a mechanical obstruction, meaning your ET tube is too small, or you have big secretions in your airway, those types of things. And then this one on the bottom right that you can see, it says for obese and pregnant patients. Really you see it in obese patients because the amount of forced exhalation that has to happen to overcome the amount of weight on their diaphragm is pretty hard. And they have to push really hard. So even with our patients, our obese patients that don't have ARDS, we're having to do a lot higher PEEP, because just think about these patients laying flat on their back or even leaning down. And then if you've given them a paralytic or sedation or anything like that, then that entire weight of their chest is collapsing and their diaphragm is collapsing. They're not able to keep any intrinsic PEEP inside of there. And the ventilator is going to have to push so very hard in order to push past that obstruction that is their chest wall compliance. So things to think about when you see those types of things. All right, so I think this is one of our, we're getting kind of close to the end. So one of the big bad things we've been talking about with our COVID patients is the risk for doing non-invasive ventilation or BVM ventilation. We kind of go back and forth what's appropriate and what's not. Is it prudent to intubate people that you wouldn't normally intubate for your own safety because you're worried about it, or if you don't have the correct PPE, things like that. But we know that non-invasive works. Our amount of intubation has dropped dramatically since we've had the options for non-invasive ventilation. So it's going to decrease your patient's work of breathing. It's going to reduce the amount of fatigue that their body has because they're getting a little help. It's going to recruit alveoli. It's PEEP. It's going to push past. It's going to push past anything like tired, uncompliant lungs. It's going to push past CHF. It's going to push past fluid, pneumonia, those types of things. It's going to stent those airways open for your asthmatics, so your obstructive patients that are having trouble exhaling. It's going to stent those airways open and allow them to release all that excess CO2. And then it's also with that CPAP on there, or that PEEP, it's going to allow your oxygen to be driven down farther where you need it to go. And then if you have the option to do BiPAP, you're going to be able to augment your tidal volume, so you'll be able to give the patient more adequate tidal volumes, as well as increase their forced expiratory pressures and give them PEEP as well. So CPAP versus BiPAP versus high flow. This is a pretty good representation. So the bottom graph is a really good representation of high flow. If you have the option to do a high flow nasal cannula, these have become really popular. We've used them in the neonatal world for a pretty long time, but now we're starting to see them really thrive in the adult world as well. The problem with this, especially for the EMS providers, is the amount of flow that it takes is tremendous, and we just don't really have access to that amount of oxygen. So if you're in a facility and you have a patient on 40 liters or 20 liters on high flow, you may meet a team, an ambulance crew or a flight crew that is simply going to say, I have to intubate this patient or put them on BiPAP because I will rip through my tank in 20 minutes. And this is a 45-minute transport or a 2-hour transport. So those are things to think about. Is unfortunately, with those devices, you're going to have to know your tank factors and decide and do those calculations and decide how long you can maintain something like that, which is kind of putting yourself in a rock and a hard place. But if you can do it, they're really great devices. They're working really well. And basically what I've been calling this, or I've been referring to it as ghetto CPAP. So you're putting a bigger cannula, a wider cannula in your patient's nares. You're taking up closer to 80% of their entire nares. So it's not that tiny little end tidal cannula. You're taking up more of their nares, and you're going to be giving them higher flows. And then when they exhale against there, it's going to cause back pressure, which is going to in turn turn into PEEP and deep down in their lungs. So you're basically giving them CPAP without having to put some big apparatus on their face. This works really well for people that are very anxiety ridden and can't handle a big CPAP or BiPAP mask on their face. And you may even be able to do this for a few minutes and then be able to put them on CPAP or BiPAP. So it may just be a bridge for you. Your top number up there is just a good representation. If you're just doing a straight CPAP device, especially the commercial devices that you plug into your flow meter, crank that sucker up to 10 or 15, and you know you don't really have an option. You're just giving 10 of CPAP. Some agencies have some different ways to deliver that, but make sure you just know your limitations of your device. And then BiPAP, these will have to be done on a ventilator most likely, and you'll have an inspiratory pressure, and that will give the patient a certain amount of tidal volume, and you will have an expiratory pressure, and you'll be giving, that will be your CPAP pressure. Go ahead.
A question from Kendall Starr. What about CPAP/BiPAP versus ventilator for risk of contagion?
Right, so that is kind of our moral and ethical issue that's happening right now. And I'm pretty sure it's on the next slide, because when I was looking through the CDC guidelines and things like that, it basically says don't do this. So I can't really tell you to do this. I can tell you why it works. And I can tell you that I've done this on patients that are suspected COVID positive, but I also had a PAPR on, and they were also brought to a negative airflow room. So the CDC guideline is that if you have to do this, you should be in full, you should be in a full PAPR, and the patient should be in a negative pressure room. There is also something in there, I think I put on the next slide, that it said if you do this, you should do this with the ambulance doors open. I'm not sure how we can just pull over and do that on the side of the road or anything like that, but that's kind of the things they're saying. So honestly, if you don't have a safe way to do this and not infect yourself with a COVID positive patient, then intubate the patient. I mean, that's kind of what it's coming down to right now, if you don't have a way to protect yourself or a way to properly decon your ambulance afterward or your aircraft afterward. So definitely work within the confines of what kind of equipment you have. But this is one of the procedures that is high cough inducing and high droplet projectile. So if you are coming up with hard and fast rules, such as we will not do those types of procedures if we have a COVID positive patient, then CPAP, BiPAP are kind of off the table for you. I would tell you, I think a high flow nasal cannula is still okay. We've been transporting our little kids high flow nasal cannula with a mask, just with a surgical mask on to kind of absorb the big droplets. And then we've also been draping our prams when we walk through anywhere so that those bigger droplets kind of don't go anywhere, since we don't have access to the big plastic domes that we've been seeing around. But yeah, so if you cannot do this safely, this is not going to be something you can do. All right, so here's the other big bad no-no that they've been talking about right now is the nebs. So this has been a debate I've been seeing online a lot lately, is that basically the CDC came out and said, don't do this. But what if your patient needs it? Then what do? You know, what if you don't have an MDI? Or what if your patient is so tachypnic and so full of fluid, dumping in an MDI is not going to do anything. It's not going to give you the deposition that you need. That has been my moral issue. And so even through my physician advisors, it's been, we have the PPE for you. Please continue to do the care that people expect from us. So as long as I have the correct PPE, I'm going to do what I need to do. You guys can see on there doing some research. I found this pretty cool neb setup. I'm sure there's more. I just didn't have time to research it, but it's called the Teleflex ISO neb setup. So you can see that it's kind of all contained. It is still not going to be 100%. I've seen some really cool adult hoods that are going on that you can nebulize inside the hood. So this is really, I mean, a super uncertain time. So I'm going to tell you to follow your gut if you don't have the proper PPE, because I can tell you if someone said, hey, Melissa, go transport this patient, and I don't have gowns, or I have gloves and, you know, a yellow mask for you, but they are COVID positive, I'd say, yeah, all right, I'm going to find a new job. You know, so, I mean, you need to do what's right for you, but this has also been a struggle for me to provide the care that I know is right. So this is gonna be a debate, guys, and I'm, you know, happy to go back and forth and have conversations about it. And it's gonna kind of come down to your personal comfortability with what you have and what your protocols are and things like that. So there's ways to do this. It's hard to see in this picture with the BiPAP, but right behind the BiPAP, right behind the nebulizer is a filter. What I would tell you is that I would flip this. I would put the nebulizer literally right at the end of this blue connector on their mask, and then leave that blue tubing to give some room before your expiratory side of your circuit or your expiratory filter, because that filter is going to get drenched and then it's not guaranteed to work for you. And this is really not on there for the patient, that's on there for us. So how we set this up determines how safe we are and how much we're protecting ourselves. It isn't like, oh, throw this on so the next patient doesn't get it. These filters are for us, are for me and you, to protect us. So some interesting stuff I found online as far as where to put those. You can look up, I have some references at the end. Like I said, EM Crit had a lot of great pictures on there. IA Med's been putting out a lot of great stuff as far as pictures and things like that, to come up with ways to protect yourself and still give the kind of care people expect from us. So any other questions on that?
I don't see anything online.
Okay.
There was some questions, and maybe I should have backed up a little bit. There was a question earlier about some of the filters, where people can find those. I did a quick internet search, and some and found some links to send them. And then folks down at City of Yuma said that they had acquired some from Boundtree. So
Yes.
if you have any kind of information that we can pass on where people can buy those filters, we'll make it available on a blast to the agency.
Yeah, and if, like I said, because it hasn't been real widely known, but all of a sudden now filters are everybody's best friend. But any place that you order your respiratory equipment from, whether it's Boundtree or anything like that, any place you order your ET tubes from, your nebs from, they should have access in their catalog or whatever if you tell them what you need. And you need to have a bacterial filter and a bacterial and virucidal filter. And make sure that if they send you one that says HME on it, it says HME and then an F, meaning it's a filter, not just a heat and moisture exchanger, because sometimes those can be really confusing. So make sure it's a bacterial filter, not just an HME.
Follow-up question from Travis. On the handheld, isn't there an opening for air to get out of the end of the rib tubing on the neb?
Yeah, and that you just couldn't see it in that picture. But there's supposed to, that thing is supposed to push it back toward that bacterial filter. So I think it's just to decrease the amount of pressure and flow that's in there, that corrugated tubing, because there's a full stop on the end of that corrugated tubing, and it's supposed to direct all the expiratory flow out through the filter. So it's, I don't know, it's a pretty interesting device. I probably need to watch a little bit more on it, but like I said, I found this a couple hours ago when I was looking at ways to hook nebs into different devices and things like that. So.
Question that I had was posed to me the other day about capnography. With all of the filters and the cap note, the concern was dead air.
Yeah, and you're just like, look, let me go down a little bit further. Here's my slide at the end. Yeah, you can add tons of stuff to these circuits, and you will not, and all those things are going to increase your dead space. So like I said, these filters normally have somewhere between 20 and 30 cc's of dead volume in there. So if you have 3 of those suckers on there, you can have, you know, between 60 and 90 cc's of dead space. And then if you look, you know, depending on where your ET tube is, and if you have, you know, a rescue pod, and if you have all these other things on there, those things can all increase the amount of dead space that you have. So what I like about this picture down here is that you will see in your end title, you will see, like I said, that rise from baseline, meaning you're retaining CO2. And sometimes you will even see it dip down below baseline and remain down there, and that will become your new phase 1, depending on how much CO2 you're actually retaining. So if you are suspecting of that and you can't take anything out, because a lot of times I would recommend for people to take certain things out or decrease the length of your vent tubing and stuff like that, you can't really do that in this day and age, in this time that's happening. But definitely pay attention to your end tidal, because that'll be really indicative of how you can see those things going and how you see your dead space rising.
So again, I'm hogging because I can. I'm the only one without the. Is there an absolute minimum on the attachments?
I would say 1 expiratory filter, and I would say put it as close to you, to the caregiver, as possible, farthest away from the patient on the expiratory side. And that'll decrease your chances of ruining that film inside of there, and more chance for it to protect you, and your end tidal. I would say those are your 2 minimums. And then sometimes I've even seen like bigger end titles, like adult end titles used for babies, and sometimes I've even had to take those out. But for most of our adult patients, I would say your end tidal and your expiratory filter are your absolute 2 must-haves. Any other questions? I'm kind of flipping around here now. This is just a picture when I went up and worked with some people at Medevac to make sure we had all the equipment and where we were going to put our filters and things like that. We kind of just opened the circuits and see what we had and where we were going to put those things in. So you can see that green elbow. Not everybody's going to have that green elbow, and not even did every single one of our vent circuits have those. So that's not a must-have, but right behind the green elbow is the end tidal, and there's an inline suction at the end of there as well. But that inline suction is not going to work if you have a 90-degree elbow on there. So you're going to have to take that elbow out if you are going to want to use your suction for that, because you're just not going to make it around that 90-degree corner. But you can see that I've seen a lot of people put that, do the bacterial filter and then the corrugated tubing, but try and put that as far back as you possibly can. I know I keep saying that over and over again. So yeah, here's what I was talking about, guys, when we talked about the wording, and these bullet points are pulled directly off the CDC recommendation on their website for EMS. So it's, it says on there, contact medical control before you do that. That may be a change for a lot of us, to contact medical control before we give a neb. You're going to choose a higher level respirator instead of just a face mask and some goggles. So these medics up here in the upper left-hand corner that just have eye protection on and a mask, if they decide to give a neb, they need to up it a little bit, I would say. Exercise caution. So these are all the things that they list as those big high-risk procedures. So you're going to have to outweigh what kind of equipment you have and your level of comfortability with that equipment and things like that. Everything should have your filter on there, they recommend. So we showed a lot of different ways to accomplish those things. Every organization should consult their ventilator equipment manufacturer. That is true. I mean, they're evolving with us right now, and they know before, when they didn't make you have filters, they know that that's part of their ethical duty to us now, is to help us figure out how to incorporate those things into there. So make sure that you are putting those where they recommend. And most of these ventilator companies have RTs or paramedics, some sort of clinical staff there that have worked in the field and have worked in the ER and things like that, so they can help you get those things going. And then the bottom one I found was kind of funny. I was going to take it out, but I figured we should all look at it, is to keep your back doors open during aerosol generating procedures. And it should not be done in pedestrian traffic. Please do not stop in the middle of a highway and open your doors to give a neb. So this is, I don't know, this is going to be a debate, and it's going to have to be whatever you guys are comfortable with your PPE. All right, so I wanted to put in here, how can we practice? So let's say you talked about ventilators years ago and now you don't use them anymore, but now all of a sudden, as an ER tech or something like that, you're going to be asked to manage ventilator patients, or as a nurse, an ER nurse that hasn't done ICU in a while, you're going to be asked to do those things. So down there are a couple of places where I have gone. And I do a lot of CEs online. I take a lot of people's ventilator classes because I like to see and learn from other people and learn new ways to teach and things like that. So Open Pediatrics is a website that I'm on pretty often. They have some great clinical questions on there, lots of CEs to share. And then directly, I use the Hamilton ventilator, so I've been on there using their medical site for a long time. And then the bottom one I just listed is from IA Med. That's a great group of instructors from all over the United States. They're a collaborative education group, and they have great education on there. And because of the pandemic right now, they've made their ventilator management class free. So all you have to do is go on there and register, and it's a completely free class for you to take. I do like the Open Pediatrics one. It's actually like, if you've done neonatal resuscitation, it's like that. It's like you get a patient and they give you an ABG, and you get to go in, and it's like a pretty fun little interactive video game. So those are different ways to practice. I'm pretty sure there are several other ventilator companies, but like I said, I've been working overtime a lot like you guys have, so I haven't had time to pull and prepare for this one as much as I normally would. Any questions on those websites, guys? Those are my, those are a lot of the resources that I use to put this stuff together in case you guys have any questions about that. But I wanted to give you guys and see if Jeff would be okay if anybody wanted to pose any questions or scenarios, or even show me a picture of their ventilator or anything like that, that we can kind of fill the rest of the time with and have kind of a discussion.
Had a question from April. So the suction port on the street tube, a source for infection, the filter doesn't cover that, does it?
It doesn't. So yeah, if you have that little blue port that you can put a suction catheter through, once you pull that suction catheter out, now whatever I would consider the end of that contaminated. So that might be something, yes, it's in line and it's decreasing your chances. I would not necessarily take it off, because it's versus if you have to pop the patient off and just completely drop a suction catheter down there, that is a very high exposure risk. But I would definitely be careful with the end of that, because your filter is behind it. And I'm not 100% sure that air could not leak out of there. But then the outside of that, because you pulled the suction catheter out of it, would then be contaminated at that point. So you need to make sure that you're never touching that part with gloves or without gloves or anything like that.
April, did that answer your question? And she said ours is not capped at all.
Yeah, that's it's kind of, these are kind of the things we're running into, is that people have equipment that seems really good, but because of how infectious this is and how strong this virus is, so we're hearing, I've heard all sorts of things from the CDC. I've been hearing like 6 to 7 hours that it can live on hard surfaces. So that means the back of your ambulance, the end of, you know, that the suction port, all that kind of stuff. So I don't know if it's right to have to wipe that down afterward, if you have your virucidal wipes in the back with you, to be able to wipe down the outside of that port after you're done, or something like that. We're having to adapt equipment and change equipment that we haven't really done before. So you're not really in the wrong, as long as you're doing the best you can for your patient and yourself at the same time. So that may be a lesser procedure for your patient, but it's simply because you need to protect yourself. I know that for us, we weren't flying our COVID positive or suspected patients for the first couple weeks that this was going on, because we didn't have a true way to keep our pilots safe and to decon the aircraft. But that's evolved and we figured that out. But that just kind of shows you that how could a helicopter transport company not send the helicopter, but we weren't able to safely do it. And so we had to stop for a little period of time. And we've seen a lot of companies been doing that until they can figure out a good way to mask fit their pilots and to decon their aircraft properly. Any other questions, guys, or anything? Stations?
Just a statement, a leaking ET cuff is a significant source of COVID blowing back out.
Yes.
This is a $5 solution to make sure your cuff is at the right pressure. It's just a 1 cc syringe with a red green zone and springs. I've seen those, and they put the link for folks to go get that.
Okay. Let me see if I can see what chat you guys are doing.
Yeah.
Because I can't really see your chat group.
If I throw that in front, can you see it now?
No, do you want me to stop screen sharing and we can maybe just discuss things?
Send the host back over to me, maybe. I'm trying to find it too.